Okay, so good afternoon again. My name is Barbara Fain. I'm the Executive Director of the Betsy Lehman Center for Patient Safety, and I want to welcome you all to today's Learning Collaborative on barriers to help seeking for healthcare workers. For those of you who don't know us, the Betsy Lehman Center is a Massachusetts state agency. We have a number of programs that support the healthcare workforce in dealing with the day-to-day stresses of delivering healthcare, and also in cases where there have been unexpected traumatic events that are impacting clinicians and staff. So what we have found is, we have these, terrific programs. The challenge that we face, and I think everyone faces, is how do you, really encourage clinicians and staff to avail themselves of these resources. And today's program is going to be focused on these very real barriers to help seeking that I think are somewhat unique or have unique dimensions for the healthcare workforce, and hopefully some ideas for overcoming those barriers. So, without further ado, I'm really pleased to introduce Linda Kenny, who is the director of our peer support programs, and she's going to tell you more about this today's learning collaborative and introduce our wonderful guest speaker. So, Linda, over to you.
Thank you, Barbara. I appreciate it. Hi, everyone. I'm Linda Kenny. I'm the director of the peer support programs. Most of you already know me, but I'm going to quickly just say that this learning collaborative and these webinars came about because after our pilots in 2019, 2020, we did actual interviews with people that we worked with at each facility. And what they said is they want it brought to them. They want the specific information brought to them so they didn't have to look for everything. So we do that in a newsletter called Support Report, and we also do that in these webinars, bringing information to you. So I appreciate you. And we're really excited today to have our speaker today, Dr. Dan Saddawi-Konefka. Did I do that right? Okay. He completed his medical degree and MBA at the University of Michigan, followed by anesthesiology residency and chief residency and critical care fellowship, not too much, at Mass General Hospital, and a medical research fellowship at Harvard. He now serves in his 10th year as program director for anesthesiology residency program at Mass General. His research focuses on optimizing healthcare professional performance through self-regulation, effective feedback utilization, and addressing barriers to emotional well-being. The work led him to the co-founding of the Emotional PPE Project in 2020, a national nonprofit that connects healthcare workers with free therapy services and advocates for reforms, to improve health-seeking behaviors among healthcare professionals. That's the focus of today's presentation. And I just want you to know, we, as soon as we saw early on the emotional PPE, we put that as a resource immediately. So we didn't know you, Dan, but we were utilizing all the stuff that you had on PPE. So thank you.
Thank you.
Welcome.
Thank you. Thank you very much. Very generous introduction, and thank you so much for having me on here. I see a lot of friendly faces in the audience. It's good to see you all. All right, I'll share my screen here. All right, and with that, I think I no longer see you. If there are any big things, please let me know, though. All right. So just to start off, I guess, by the way of disclosures and caveats, I don't have any relevant financial disclosures. I did co-found and serve as president of the Emotional PPE Project that focuses on this, but I take no money from the organization, and I actually donate every year. the other sort of caveat, a lot of the data that I'll present here is around physicians, and that's just because that's what a lot has been published on. It's my belief that that these barriers extend to all healthcare workers. There are probably some nuances here and there, but you'll see, I think broadly, these all seem very applicable to all healthcare workers, and lack of evidence is not lack of need, especially when there's just so much commonality. And then lastly, just as a caveat, we are talking about one very small piece of well-being, sort of one of the cornerstones of well-being is that that safety net, I guess, and then we're really talking about just that small slice. So just to acknowledge that up front. The talk overview will go over the background, so the current state of mental health and help seeking amongst healthcare workers. We'll talk about barriers, and we'll talk about a lot of the work that's going into solutions to overcome these barriers. These first two will sort of be they don't feel good to go over all the data, but I think that it ends on a quite uplifting note because there's just a tremendous amount of work being done. Now, I was told early on in my career that when you're giving a talk, you should tell people what you're going to tell them, and then tell them it, and then at the end, tell them what you told them. So in that spirit, these are the takeaways of the talk. Okay, so number one, healthcare workers have high mental health needs. It's higher than you'd predict if you compare it to sort of age match outside of healthcare workforce. That results in significant morbidity and a higher risk of death by suicide. Along with that, treatment helps. It works. Connecting people with professional mental health care decreases distress. It decreases risk of suicide. But unfortunately, healthcare workers are very unlikely to seek help. Number two, the barriers are many. Broadly speaking, we have a culture that normalizes, or I'll go beyond that, it even celebrates inadequate self-care, and that gets in the way. We have stigma, which leads to these really big fears of professional repercussions. And then we have logistical challenges, and those are often compounded by the fears because of confidentiality. People don't want to go within their own systems. They want to pay out of pocket, and it makes the logistical things much more complicated. Three, we can remove these barriers, and there's a lot of people who are working to remove these barriers. The solutions, broadly speaking, include education, role modeling, and leadership, systems and policy reform, and innovative support programs, which the Betsy Lehman Center is certainly no stranger to. Now, I want to start up front, sort of with sort of a request that many of you probably already think this, but that we not sort of reduce all forms of distress to just calling it burnout, because I don't think that does us good service. And disambiguating sources of distress is important. I'll give you sort of one example of a way to categorize them. You have mental health conditions, things like depression, anxiety, PTSD, and you have occupational conditions, things like burnout, moral injury, compassion fatigue. And these can certainly overlap. I can tell you, at least amongst my residents, anytime someone feels distress, they're the first thing they say is, oh, they're just feeling a little burned out. And it's a maybe they are. But these all can manifest as distress, but they differ quite meaningfully in terms of their etiologies, their consequences, their treatments, their preventive approaches. And I'll circle back to this in a little bit. But if we call everything burnout, the solution for burnout is not therapy. Therapy doesn't hurt it, but it's not really where the fix is. Most people know that. So if someone accidentally, inadvertently labels depression as burnout, they're foregoing the most effective thing they could do, which is connecting with professional mental health care. So sort of a plea up front that we maybe start using the word distress rather than burnout, when really what we mean is distress. Mental health burden in healthcare workers, depression. Now, these are based on screens, so they're not formal diagnoses, but they are very common. And these are more common than you'd otherwise predict, especially when taking into account things like socioeconomic status and so forth. Depression, it's about 30% of physicians, for example, will screen positive for depression, 25% for anxiety, 10% for PTSD. Now, burnout, very common as well. It's 25 to 75% depending on the setting. But we talk a lot about that, and we don't talk as much about these. And just for context, the prevalence of diabetes in the adult U.S. population is about 10%. It's about the same incidence of PTSD in healthcare workers. And this is not COVID data. This is just PTSD in general. So these are very common conditions that really deserve some airtime. What are the consequences? Just briefly, they're fairly profound. So, patient care in that people will report poor workability. They're more likely to reduce their hours or leave the workforce entirely. And work satisfaction goes down. A lot of healthcare leaders, I think, care very much about sort of survey results for well-being, and they think about all sorts of things to help. But untreated mental health conditions is a huge lever to pull. It's 3.5 times less professional development, 2.5 times less work satisfaction, and we know that we can substantially reduce levels of distress from mental health conditions by connecting with professional care. So the consequences for the system are fairly profound. Consequences for healthcare workers themselves are even more profound. There's a huge impact, and I won't get into the weeds because I suspect that most people take this as face value, but there's a lot of literature on this. Huge impact on quality of life, huge increase in personal and professional levels of stress, and suicidality. Amongst physicians, 6 to 14% across different studies of med students, residents, physicians in practice have reported suicidal thoughts in the preceding year. It's a lot. It's 1 to 2.5% have attempted suicide. And suicide is currently the #1 cause of death in graduate medical education trainees. It's more than cancer, more than accidents. It's the #1 cause of death. The suicide risk extends across all healthcare workers. So where I do have some data to share for other role groups, I will. This was published in JAMA in 2023, and this is compared to sort of matched peers not in medicine. The risk of suicide you can see is substantially higher in registered nurses, healthcare support workers, and healthcare technicians, all excluding parity. There was a pretty robust analysis that came out of the National Violent Death Registry in January of last year, looking at what's different about physicians who die by suicide as compared with non-physicians who die by suicide. And I think this is important because not that our sole focus will be suicide. There's also just tremendous distress to alleviate. But if we're thinking about this as one of the things we want to address, what's different about it will tell us where our opportunities are. And I think that has a huge tie-in for things like peer support I'll mention in just a moment. But if you look at it, these are all individuals who died by suicide. The ones who are physicians who are more likely to have depressed mood, mental health problem unaddressed, were more likely to be involved in a legal proceeding or a job problem. And when we get back to towards the end, what some of the levers are, think about where peer support is deployed, where it ought to be deployed, either reactively or proactively. It's often when these things come up. Peer support is not therapy, but it can be a critical bridge to therapy when red flags accumulate. It can also decrease, as we'll talk about, isolation, normalize help seeking. So why are suicide rates higher? Why would this be? Well, one is work characteristics. We work in high stress environments, both in terms of workload and also critically the cost of errors. And when you couple that with the characteristics of the attributes of people who come into healthcare in the first place, they commonly have traits like perfectionism and altruism and competitiveness. And when these errors happen, it creates a unique set of sort of vulnerable context. Second is knowledge and access to means. Healthcare workers, by their training, are more likely to know how to complete a suicide as compared with someone else. And we do have data, for example, that physicians who attempt suicide are more likely to die by suicide than non-physicians. And then finally is barriers to help seeking. And there's a lot of data on this from psychological autopsy studies looking at how many of those who died by suicide where physicians just had no connection with mental health care at all. We just looked at that paper a little bit ago that echoed that. But the bottom line is that physicians who die by suicide are less likely to be receiving mental health care than non-physician peers. So taking this as a roadmap, what could we do? Well, the work characteristics, it's going to be hard to change that. The cost of errors will always be the cost of errors. We can minimize errors. That may help, safer systems. But those will always still be there. Knowledge, we won't really be able to change. Access to means, maybe there's something to do there. But barriers to help seeking, this is the one that just, why do we have these at all? So I'd sort of submit that this is one of the biggest opportunities we have to help with this issue. Now zooming out a little bit back to this slide, I said that disambiguating sources of distress is important. I want to give one concrete example why. So depression independently predicts suicidal ideation, but it actually does not independently predict medical error. Conversely, burnout independently predicts medical error, but it does not independently predict suicidal ideation. So depending on what we're trying to fix, we need to have targeted solutions, and we need to be careful with our terminology, because if we allow burnout to be synonymous with distress, then healthcare workers may delay or forego treatment entirely that would be effective for them. To say that if we got rid of barriers, things would be better, sort of presupposes it rests on the assumption that therapy, professional mental health support is effective. So just a brief aside on that. This is all comers. These are not healthcare workers specifically. This is one study over here. What they did was they took patients who presented to the emergency room after an attempted suicide, and they randomized them. They didn't randomize them to nothing. They randomized them to care as usual. So outpatient follow-up, groups, that sort of thing, versus professional mental health support. And in the ensuing 18 months, the number of suicide attempts in the cognitive therapy group were cut in half. We see this, this is just a systematic review of similar randomized trials. Overall, the relative risk here of future suicide attempt is 0.47. So really, with professional mental health support, we can cut suicide attempts in half, is what this comes down to. Therapy also cuts symptoms in half. This is a multinational study of physicians. Sorry, it's a systematic review, multinational across 3 continents of different studies, looking at anxiety, depression, overall distress, and the effectiveness of mental health, professional mental health. And overall, we see that it cuts distress by about half. The problem is that fewer than 1 in 3 physicians, and again, I don't have great data on non-physicians here, but I'd say it's pretty typical for other professionals as well, just don't seek care. And so one way I sort of like to think about this, because it anchors me on a person, here we have 3 people. This one would seek help, these 2 wouldn't. We know that we can cut the rates of distress in half. We know that we can cut the suicide attempts in half. If we could connect those 2 with care, we could save 1. So that's the background. We'll jump into what the barriers are. Why is it that we don't seek care? And broadly speaking, I put them into 3 groups. One is that we have a culture that promotes inadequate self-care. We sort of celebrate coming to work sick, working through anything, look how tough we are, look at it. And we teach this not through explicit curriculum, but to the people who are joining the profession. The second is that we confuse mental health conditions with impairment. We ask about them in the same breath as if they're the same thing. And because of that, people worry that if they were to out themselves as someone struggling, there would be consequences. And then the third is logistics. We'll dive into each of these. So across conditions, physicians, and I'd say all healthcare workers are less likely to seek care. There's this pervasive hero culture. There was a study that looked at a large number of generalists in practice. 96% of respondents agreed that physicians, that doctors feel they need to portray a healthy image. Second is that illness and distress are minimized or characterized as a phase. And I suspect every one of us could think back to some time when we thought, oh, if I get to the end of this clerkship, this observership, this just once I finish those exams, whatever it is, life will be a little bit easier. But we keep doing that. We keep extending the tunnel. And what happens as a result is that we sort of see this as normal within healthcare. Running sort of half empty is seen as normal. And then if help seeking is encouraged at all, it's really only when we get down to here, but there's just no reason that this should be normal. And finally, I think it's both because of concerns if they were to seek formal help, and also maybe inflated senses of how well we can take care of ourselves. Healthcare workers often choose informal care or self-treatment. This was sort of a sobering statistic I saw across a couple of studies. 9 to 15% of physicians, these are not depressed physicians, these are all respondent physicians, 9 to 15% reported self-prescribing antidepressants. In a survey of almost 400 psychiatrists, fewer than 50% said that they would seek formal professional advice if they had a mental health condition. Most said that they would opt for informal advice, self-medication, or no treatment at all. So this is the culture that we expose people to. The next thing is the stigma, the fact that, beyond that, we actually confuse illness with impairment. And we kind of do it uniquely for mental health conditions. If a colleague with asthma or a colleague with diabetes, I think we unfortunately see them differently than a colleague with depression. When someone has a flare of depression, we treat it differently than someone who has a flare of Crohn's disease. And it's a little bit funny, but I think it's because we confuse that with weakness. This was another large survey. The majority of physician respondents agreed that the following beliefs were common in medicine. A doctor with a history of depressive illness is seen as less competent. Suffering with depression is a sign of personal weakness. And many doctors think less of doctors who have suffered from depression. Now, it's interesting. It's something that we, I think, do actively. And the reason I say that is 25% of med students are reluctant to seek care because they fear that using services will mean they're weak. But that fear of stigma increases. It's 58% of residents. So it's something that increases over time. And that same thing drives that profound desire for confidentiality. It's 37% of med students, and then it increases to 57% of interns, and it's 2/3 of practicing physicians. And the fears of career implications are substantial, and unfortunately, they're rooted in some reality of certainly the past, and probably to some extent the current. Although, as we'll talk about, there's a lot of change ongoing there. These fears are very common. 85% of practicing physicians say they'd be reluctant to share diagnoses with colleagues, and the most common reason is because of career implications. This was an incredible talk. It's available on YouTube if you want to see it. This is Dr. Carrie Cunningham. She's a surgeon at Mass General. She was the president of the American Academy of Surgeons. And she gave this incredible address called Removing the Mask. And in it, she talked about her own struggles with mental health conditions and substance use. And she started it by saying, I know that giving this address will change my career path. There will be jobs that I'm not offered. There will be doubts as to my abilities. There will be people who see me as weak, emotional, and damaged. And I could not be more grateful to folks like Carrie to help normalize that these things are so common, and we need to talk about them, and they're not weakness. This is the president of one of the largest surgical societies in the country, let alone the world. But this is what the fear is. And historically, we've seen this. We've seen this on applications. I'll get into licensing applications in a little bit, but I'll show you this is an older study. This is 1987. There's just not newer studies. I wouldn't be surprised if it was the same thing. What they did was they made up applications. These were fictitious applicants. but they were all the same. They were all the same. They didn't have any impairment. They were all about middle of the road performers. These are applicants to residency. And they sent these fake applications to 500 plus program directors. The catch was that in half of them, they said that this person had a history of seeking help. That's it. They'd gone for professional counseling. But again, no impairment, nothing different. Those who had that history in this fictitious thing were scored 12 to 14% lower for likelihood to get an interview or likelihood to match. So we confuse illness with impairment. State medical boards, there's been a lot of attention over the last 6 years or so. Back in 2007, 1/3 of state licensing board directors felt that a diagnosis alone was grounds for sanction, even just temporary sanction on a physician trying to get a license. And why would they do that? Well, they're not trying to be mean. They're trying to protect the public from impairment. So what does it mean? It means that they're confusing illness with impairment. There is no evidence, there has never been evidence that this practice improves patient safety or outcomes. There's actually some evidence that maybe suggests it would do the contrary. It's a 2017 study that came out of Mayo. 2/3 of licensing applications were still asking broadly about mental health conditions without impairment. Or they would do these things, they would ask about hypothetical impairment. Do you have any conditions that could affect or potentially could affect your care? By the way, asking about illness without impairment, asking about hypothetical impairment, these are at odds with the ADA, the Americans with Disabilities Act. They're discouraged by the Joint Commissions. They should not be happening. But in 2017, 2/3 of states still asked these questions. And what they did in this study was they also surveyed physicians in those states. And physicians in states that asked those questions were 21% more reluctant to seek help. Those potential disclosures are not limited to licenses. We see them on credentialing and privileging forms. We see them on disability insurance, commercial insurance, malpractice insurance. And even if we got rid of all that, there's always the fear of discovery in some sort of medical legal case. This is a licensing question from 2020, just to make it a little more concrete. I'm very happy to tell you that this state has revised their question. This question is now of historical significance only. But look at this. Check each question you have ever been diagnosed with, treated for, or currently have. Bipolar, hypomania, schizophrenia, depression, seasonal affective, so on and so forth. Nothing about impairment here. This is just, have you ever had these? In 2018, the Federation of State Medical Boards, this is an umbrella organization. They don't have, they can't compel boards to do anything, but they give recommendations to all the state medical boards. They put out recommendations for supporting the well-being of physicians. And they had 10 recommendations overall. 4 of them were actually evaluable on licensing applications. So first was only ask about impairment. Second was only ask about current stuff. Don't ask about historical stuff. And usually this is operationalized as stuff within the last 2 years. Third, offer safe haven non-reporting. So all states have, for physicians, for example, physician health programs. And so if there's someone who, even if they had an issue, if they're in good standing with a physician health program, they can answer these questions as if there's nothing to report at all. That's called safe haven non-reporting. And the fourth was to offer supportive language or normalizing language, that these are common, that this is okay. So what our team did in 2020, we pulled all of the states' licenses because this was a couple of years after these recommendations had gone out. And we looked at all 50 states and a handful of territories to see where do things stand. Wasn't a good report at the time. There was only one state, North Carolina, that was doing all 4. There were 5 states that did none. This has been improving dramatically. There's a lot of folks who are championing this. Many of you may have heard of the Lorna Breen Heroes Foundation. They've been doing a lot of, they've done a really great job in galvanizing a huge movement around this. In 2023, this got the attention of some of our senators, and Senators Wyden, Booker, and Merkley urged the Department of Justice to protect physician health privacy and to hold states accountable for violations of the Americans with Disabilities Act. And they got an affirmative response. basically said, if you are aware of anyone who has been subjected to the type of discriminatory licensing inquiries referenced, we ask that you please encourage them to file a complaint or reach out to the department directly. So we've seen broad sweeping changes across state licensing, across the board for physicians, for nurses, for pharmacists, and so on. We repeated this analysis just 2 years later. We found that an additional 8 states now only asked about impairment, an additional 4 limited to current, and this now is 2023 data or so. So things have gotten better even still. If you go to the Lorna Breen Foundation, it's whatever their URL is /remove barriers. You can actually see where your state stands for your licensing application. They actually also have a list of what are called champions. That means that they've actually gone through the work of making sure that their credentialing applications are also best practice. And they list all the healthcare systems that have done that. We've seen other pretty amazing things here too. In 2023, Virginia actually passed a state law, HB 1573, and it basically required all healthcare employers to remove any existing questions around mental health conditions and impairment. So you can ask nothing, and instead you can ask these 2 questions if you want to, anything. First, do you have any reason to believe that you would, this is not a hypothetical, that you would pose a risk to the safety or well-being to your patients or clients? And are you able to perform the essential functions of a practitioner in your area of practice with or without reasonable accommodation? The idea being that we don't have to choose. There are, of course, we still want to keep patients safe. We do want to look for impairment, but we just have to stop confusing illness with impairment. All right, so we talked about the culture that promotes inadequate self-care. We talked about the professional consequences. Let's briefly touch on the logistics. So first off is that time does not always seem possible, and that's due to a number of things. One is we have quite demanding jobs, and 2 is this really, really deep-seated sense of duty. 1/2 to 3/4 of physicians cite time as the primary barrier, and 3/4 of them say that if they were to take time to do this, they worried that they would be letting their colleagues down. This was a really nice qualitative piece, sort of like trying to explore what are the unwritten rules. So you don't, people don't seek help, but why is it? Like, what is it? And so they interviewed a bunch of physicians and then came up with this informal shadow contract, and then they validated it with future interviews. And I'll read it here to you so you get a sense of what the culture historically was, and then I'll suggest something to you also. Here it is. I undertake to protect my partners from the consequences of my being ill. These include having to cover for me and pay locums. I'll protect my partners by working through any illness up to the point where I'm unable to walk. If I have to take time off, I will return at the earliest possible opportunity. I expect my partners to do the same and reserve the right to make them feel uncomfortable if they violate this contract. In order to keep to the contract, I will act on the assumption that all my partners are healthy enough to work at all times. This may mean that from time to time, it's appropriate to ignore evidence of their physical and mental distress and to disregard threats to their well-being. I'll also expect my partners not to remind me of my own distress when I'm working while sick. So here's historically where we've been. This is an older study. I think there probably still are practice environments where this feels very real. And I'd implore each and every one of us to be part of the solution here. You can normalize taking off time for your health yourself. You can find a colleague in distress and just encourage them. And honestly, I think when you face it yourself and you're like, okay, should I take time? I'm maybe feeling distressed. Should I reach out for help? Ask yourself what you'd want to be able to tell a colleague that you did when you were in this circumstance. Fast forward to now you're having the conversation with somebody else. And wouldn't it be great to say, oh, this is where I was and I sought help. I took time off. I did whatever it was. We can change this culture. And then the other logistical challenge outside of the time is this desire for confidentiality. Many choose to go out of network, which decreases access, or pay cash in order to avoid any sort of record. So if it's 55% of trainees say that if they were to seek help, they need to find a provider outside their home institution. And among depressed physicians, 21% say that if they were to seek help, they would only do it by paying cash. Okay, So that was the sort of the downer part of the talk, and now we'll transition to a lot of the amazing work that's being done, a lot of the work that we can all participate in to help dismantle or get around these barriers. I'm going to start this off by saying this. This is sort of a deliberately complicated slide. These are a list of a lot of the barriers. The issue here is that these are interrelated and they're complex. If we take out any one, this still lives on. You know, if we fixed all licensing applications, we wouldn't fix the problem. These are multi-level problems. We can't be reductive. We need multi-level solutions. So what are those solutions? Education and leadership, systems and policy reform, and accessible support programs. So under education and leadership, you have stuff like this, honestly, like the programming that the Betsy Lehman Center does and talks like this that stress a few things. One is the commonality of mental health conditions, along with the effectiveness of therapy. I think there's a lot of doubt as to whether or not it could help. The other piece, and this is a really critical piece, we have to educate people. We have to let people know, and this comes a lot through role modeling, that sense of identity that you have of being clinically excellent, of being this incredible clinician, this incredible healthcare worker, is completely compatible with seeking help for your own distress. In fact, these two are probably mutually enforcing. You know, if you were to seek help, you can reach new levels. And we sort of have to break this false dichotomy of like, if you get this, then you are not this excellent clinician. We also need to do some work in helping people recognize distress in themselves, recognize distress in others. I think just given the audience here, I think peer support training is a really good way to approach that. So if you haven't gotten involved with the Betsy Lehman Center, a plug for that. And then critically, and this sort of echoes to one of the questions that came in from the pre-meeting from registrants was, okay, what are the available resources? How do we get them? People have to know who to call, where to go for help, if and when they recognize the need for help in themselves or others. Leadership is critical here because you can say whatever you want, but if you don't role model it, people aren't going to believe it. And leadership is not just what we model for ourselves, but also how we take care of each other and how we talk about our patients and how we care for our patients. So when you have a patient with a mental health condition and you describe them with negative terms, other people listen. And that unfortunately reinforces that conflation. So we can all probably be mindful of how we approach that as well. Anonymous screening programs are another leverage. I put these under education because it's almost like self-screening, self-education. The one that I'll point to, there are many. Mental Health America has a large set of self-screening tools to sort of get a sense of, okay, this distress that I'm feeling, is it depression? Do I have an issue with substance use? And you know, honestly, in my mind, if you're feeling a lot of distress, I think you can move beyond self-diagnosis and just reach out for help and have a professional help you. But if you need a bridge, I think self-assessment is not a bad way to go. The American Foundation for Suicide Prevention has something called the Interactive Screening Program. This is a pretty incredible thing. It's not everywhere. I think they charge like an entire organization would be charged $5,000 a year for it, to give you a sense. The Tennessee Medical Foundation, actually, Tennessee Medical Society, I forget what the last letters, actually partner with them. They do it for the whole state. But what it is it's a self-screen, but it's coupled with motivational interviewing. So it's anonymous. You get your screening results. And if you screen high, you're anonymously connected with a motivational interviewer. It's a real person. You communicate by email type correspondence. They don't know who you are. And all they do is try to connect you with help if you're interested. But they're trained in motivational interviewing techniques. So that's, I think, a pretty innovative approach, and has successfully connected a lot of people with care. This is from one physician in training who used the interactive screening program at their institution. Systems and policy reform. So there's a lot of opportunity here. I think one of the big ones comes from, obviously there's regulations, but I think also benchmarking. So making sure that these sort of things are embedded in surveys so that we collect information on a whole bunch of stuff, but we do need more widespread sort of cultural indicators of stigma, of knowledge on how to access care, the perceived safety of accessing care, those sorts of things. There are a handful. The AMA's institutional, I think it's called institutional biopsy tool or self-study, has some on that as well. But that's one way to do it. And then, of course, governing bodies. So, for example, the ACGME mandates that residents must be given the opportunity to attend all healthcare appointments, including mental health, including those scheduled during work hours. There's a lot of work to do to get it from being something that's a mandate to get to past just checking boxes, but actually being something that people feel safe using. Licensing and credentialing reform. We went over a lot of this sort of when I was initially talking about licensing. And just to say that I think this is slowly becoming something that was only of historical significance. There still are some places that need some work. I think a lot of focus now is on the credentialing. If you work at an institution, you can check the Lorna Breen Heroes Foundation to see if your institution is listed. And if they're not, the process is actually not that hard. You can reach out directly to the Lorna Breen Foundation, and there's someone there who can help guide things along. I just a pause to say what we're talking about is a different way of caring for healthcare workers. It's a departure from what we've done in the past, and that takes resources and funding. And institutions are strapped. Their funding is not plentiful. So one of the levers has been federal funding. In 2022, the Dr. Lorna Breen Healthcare Provider Protection Act was signed into law, and it provided over $100 million in grants to improve provider mental health. It expired in 2024, but got reauthorized just a few months ago. Reauthorized means that it's reauthorized through 2030, but it actually doesn't have any funding attached to it. So one thing I'll put a plug in for right now, this QR code will be up at the end as well. If you scan it, you're taken to a page. You just put in your state, your name, and answer a couple other real short questions, and you hit click, and that will email your congressmen and senators and advocate for funding of this. You can also learn more about the act to make sure that you feel comfortable with it, but it's really just how do we decrease barriers to healthcare? How do we improve the well-being of our workforce? It still has not been funded, even though it does have bipartisan support. So easy thing to do. And then finally is accessible support programs. Peer support is I think chief among them. As I said at the beginning, it is not therapy, but it does reduce isolation. It normalizes certain struggles, and it's a critical time to offer support because it often touches the people who are most at risk of feeling most distressed, and most at risk of suicidal ideation, et cetera, et cetera. Opt-out programs are a new thing. They're not very common because they're fairly resource intensive, but they are becoming a little bit more common. And basically what is it? It flips the script. It's no longer waiting for people to feel distressed. It's more saying you're in a context where distress is fairly common. And so we just set you up to see someone. So you see these, for example, with interns. Interns have the highest incidence of death by suicide in graduate medical education is during intern year. And some programs have started to during your intern year, you're just scheduled to meet with a mental health provider. I sort of in my mind, I have this you turn 45 and you go for a screening colonoscopy. It's not because you're a bad person. It's not because we think there's something funny about you. It's just you're at a time in your life where you're at risk. And so it flips the script. It gives people familiarity with seeking help with mental health professionals. I think it demystifies a lot of the process. I think there's a lot of benefits to it, but it is expensive. And so I think it's probably going to be most used in those high-risk clinical times, or a place where I would love to see it used more often is during high adverse outcomes. So any legal proceeding, anything, you're going to meet with risk management, you'll meet with the attorney, and you're going to meet with this mental health professional, just as the standard. Like, this is just what we do. That's not currently the standard, but I think there's a lot of opportunity there. And finally, confidential counseling is going to be something that we provide. And I don't think there's one single best, this is what people should have. I think clinicians are not a monolith. Everyone's going to feel safer with one thing over another. And what we really need is diversity of options. So this could be employee assistance programs, physician health programs. The 988 crisis line is tremendous. And by the way, if you scan this QR code, you'll save a contact in your phone. And it'll just be the Suicide and Crisis Lifeline. So if you forget that it's 988, you can just look in your contacts for suicide or crisis. Or I think it's a fantastic contact to save. Why? Even if you're thinking you may not find yourself in crisis, maybe you will find one of your colleagues in crisis, and maybe you'll be worried about their safety, and maybe you won't know what to do in that moment. In that moment, you could call 988, and you will be connected with someone who is trained for exactly that, and they can walk you through it. It is a federally funded suicide and crisis lifeline. And then there's organizations like the nonprofit that I founded, the Emotional PPE Project. We do education and advocacy and research, but we also have a directory of mental health providers who have all said, these professionals have all said that they are willing to pro bono provide care to any healthcare workers who reach out. So the website is emotionalppb.org. You scroll down to find the state that you're in. We collect no information about people who visit the site, zero. Why? Because we don't want any barriers to help seeking. It makes it a little bit harder for us to tell what our impact has been. The professionals listed in our directory sometimes tell us if they got a use. We know from that we've connected over 2,500 healthcare workers across the country with free care. But we don't know beyond that. Occasionally, one of those healthcare workers will reach out to us with a message. And I'll leave a 30-second pause here for you to read this message that we got from Krista, who gave permission to share. This is the impact that we can have. You take people who have needs, and there are solutions, and it's an implementation gap, right? These barriers don't need to exist. I was given feedback in an earlier talk that it would be really helpful if I put all the solutions on one slide in case people wanted to screenshot or take pictures or so forth. So these are them all on one slide, and I'll wait here in case anyone wants to screenshot or take a picture of it. And then I'll go over the takeaways. So this is the tell them what you just told them part of it. So first off, healthcare workers have high mental health needs. These result in a significant morbidity, and it impacts our systems and our professionals. And it also leads to an increased risk of suicide. Treatment works. It really works, but people are unlikely to seek help. Why? Because we normalize or celebrate inadequate self-care. We don't role model it very well. We confuse illness and impairment. And so people have all these professional fears about what will happen to them if they seek help. And then there leads the logistical challenge, time, access, cost. There's a lot of work that's being done to overcome these barriers. And I think it's actually a wonderful time to be involved in these sort of things. I look forward to, a few decades from now where people might look back on a talk like this and say, is a talk like this even necessary? These innovations include education and leadership, systems and policy reform, and innovative support programs. So with that, this is a QR code to the JAMA paper that we published with Jess, who's the immediate past president of the AMA, Christine, the chief medical officer for the American Foundation for Suicide Prevention. This goes over a lot of things, similar things. It has a lot of the data embedded. I want to thank my emotional PPE board. Um, I also want to thank my home team. And I'll leave this up here while we transition to questions. If you're open to this sort of thing and want to give us a follow on any of these platforms, it helps us extend the reach of the messages. All the references are right. This QR code. This is the contact card for the Suicide and Crisis Lifeline. This is the way to single click do advocacy for funding for the Lorna Green Act. And there were a number of questions that came in beforehand. Tried our best, and thanks to Whitney for helping with some of the resources as well. Answer those questions in case we run out of time here. Happy to take any of those live as well, though. Thank you.
Thank you so much. We will, anybody who wants to ask a question, please raise your hand or put it in the chat. I just want to say thank you so much. There is a question, but before we get there, I want to say, I heard years ago from people who were part of the cancer, like from Dana-Farber, that hospice was something that really the healthcare community did not want because it felt like a failure to them. And now hospice is everywhere, right?
Yeah.
So my hope was that maybe someday that this would happen. And I have seen changes in 20 years, but I think you're right. We need more leadership at the institution level. And I've seen senior leaders at peer support training saying they're there to show the younger folks that it's okay to get help. And we need more of that. We need more courageous leadership for that. But so my heart is full. This was a great presentation. So, okay, Aileen, this is one of our peer supporters. She's, hi, Aileen.
Hi, Aileen.
Yeah.
Hi there. I apologize because I might have missed it. I had to step out, but could you just clarify who is eligible for the emotional PPE services in terms of provider type or where in their education or training someone is?
Yeah, great question. So the ask that we make for the mental health professionals who come into the directory is anyone in healthcare. So it's fairly broad, and we ask that they provide at least 2 pro bono sessions with them. Beyond that, I mean, it's such an incredible group of people who really, I think, find the value in altruism. I've heard of some of them extending beyond that, but we don't make a formal request to them beyond anyone in healthcare and at least 2 sessions. Does that answer your question?
So that's actually an even better question. And thank you. I was wondering, in order to be eligible to receive services, what category of human being is eligible?
I wonder if I'm misunderstanding. So maybe I'll do this. Let me.
And I may have missed you covering it because
Aileen, do you mean the role within healthcare?
So I think you're saying to get like connected with a mental health professional. Is that right, Aileen?
Yeah. So for example, I have worked in nursing. Right now, I'm a peer support specialist, which is a non-clinical role.
Yeah.
If I came in, which category of healthcare worker is eligible to get services?
Yeah, any of them. So you would just go here, select your state, and then look at the providers available. And what you see there is either their phone numbers or their email addresses, and you just connect directly with them. But any healthcare worker would be eligible. So it's a very, very I think perhaps you're asking for more specificity because it seems so broad, but it is actually that broad.
No, that's great. I wanted confirmation because as someone who's an unlicensed clinic-based, there are a lot of sort of peripherals now that are impacted similarly, but they have less access to care because of income and other issues. So,
yeah.
Thank you.
I think it's great, Aileen. Like you probably think like I do that they're including everybody who works under the healthcare umbrella who's impacted. Yeah, thank you. Okay, Jamie Well, Bullock?
Hi, it's Jamie Wallach.
Hi.
First of all, thank you very much. And I'm just gonna ask this question. I'm sure people are involved, but I'm a semi-retired pediatrician that's working as a patient advocate because I couldn't handle the medical system. I love what I'm doing. I really wasn't ready to retire, but pediatrics never fit for me. But I went to treatment and residency. I'm going to be 30 years sober in December. I never had to go through the medical board because I got help before I got caught. And I haven't done any service that way. I'm very involved with 12 step. And people need to hear this. And it's the same thing as having depression or anxiety or being non-divergent or whatever. We are good and great the way we are. We just have to know it ourselves and not be so scared. But I've gone through everything you just talked about, and it's still so present. I went to medical school 30 years ago. And so if you know somewhere where I can volunteer or we need to start something. I know there's many doctors, the health professionals, every single area of health profession can be involved in international doctors in Alcoholics Anonymous, and it's not just for AA. And it's a very established, widespread group, and they may have that. I'm not that involved. I'm busy with other things, but I don't know. I wanted to reveal that and get, because I'm sure you know other people like me, and where can we help, and if there's already established places to do that.
Yeah. So first off, congratulations on the 30 years. That's phenomenal. And secondly, thank you so much for role modeling. I mean, that like you're asking like, how do you help? It's exactly this sort of stuff. You just like, these are things that we have. We're people. And it's not our full identity, and we transcend those things. I think, the best place to help might be with sharing stories.
Mm.
There are a number of organizations that collect stories to then sort of help like normalize things. We're one of them. There was a campaign some time ago, not that long ago actually, a Shift the Culture campaign where there was a big call for collecting stories. I wonder, I see Sophie Sharp on the call. Sophie, I wonder, if you happen to have a link to the sharing the stories from the Shift the Culture campaign, if we could put that in the chat. But if not, Whitney, maybe that's something that I can follow up to for distribution.
Yeah, and Jamie, can I ask where you're located?
Sure. I'm in the San Francisco Bay Area in California.
Okay. Damn, I wish you were in Massachusetts, but
I know, and we've never, when I very first, I went through monitoring for 5 years because in case the medical board,
Yeah.
And we had what they call a caduceus group of doctors and other medical professionals that met, very small. But when I was in treatment in Atlanta, where health professionals go, there are some states that are so strong in their, caduceus, doctors helping doctors. I'm sorry, I'm always saying doctors because I've grown up before there was a lot of PA. There's a lot of PA and NP, and they're all wonderful, and any other kind of clinical care worker.
Jamie, can I connect with you offline after this?
I would love it. Yes,
Okay,
absolutely.
I'll do that. And Jackie has a question, but Jamie, we already have your information when you signed up, so I will contact you. I'd
Okay.
love to connect. Okay,
Sounds good.
Jackie.
There's a question in the chat from Joseph. If you wanted to get directly involved in supporting this work at a state level, what's the best organization to contact?
I think at a state level, I'd probably get in touch with the Lorna Breen Heroes Foundation. Well, unless you're talking about Massachusetts, Lorna Breen would be great there as well. But with Massachusetts, I think I'd probably add the Betsy Lehman Center to that as well. just tremendous reach and network in the organization.
Thank you.
Of course.
I have to get off for another commitment, but
Thank you.
I'm glad I found you, and thank you, and I look forward to continuing to work with you. Thanks so much
Thank
for
you.
all the work that you've done.
I just want to thank everybody for attending and let you know that we will be sending a survey. We really appreciate feedback, and I think we'll ask questions about what other kind of webinars you'd like. Dan, you were fantastic. I can't wait to continue working with you. And Teresa, sorry we didn't get to your question. I know Whitney's going to send out the paper with the questions and answers. And I think that about does it, right? Did I miss anything? And again, Sophie, thanks for being back up to Dan. And thank you everybody for coming. If you need anything, Aileen, put your question. I did see your question on the chat about that. No, but when we send the follow-up survey, could you put that in so we could, okay, great. And if you have any other questions, Dan apparently has this incredible time early in the morning, so he'll be happy to answer any of your questions. So thank you, everybody.